Uh, Good morning, everybody. Today I'm going to be talking about ergonomics in OR. What can we as surgeons do to protect ourselves and others? When you first start your urology and as you transition to your second year, you're working a lot on your endourology skills and trying to refine them as much as possible. And one of the things that I've been struggling or encountering while learning endourology is going home every day with a lot of back pain, muscle pain, leg pain. And I think to myself every day, what am I doing wrong? And what can I do better to try to avoid these kind of things? So today, we're gonna some learning objectives. We're gonna try to identify causes and some risk factors that are work related to musculoskeletal disorders as they relate to us in the operating room. And we'll try to differentiate between modifiable and non-modifiable risk factors and specific sources of muscle strain by route of surgery. And we'll try to go over some of the existing ergonomic guidelines and recommendations out there for surgeons. And we'll try to see if we can come up with some ways that we can include this into our practice. So, what is ergonomics? The word ergonomics comes from the Greek word ergon, meaning labor, and nomia, meaning arrangement, so labor arrangement. But essentially, it is the concept of designing the working environment to fit the worker instead of forcing the worker to fit the working environment. So, what does that mean? So, some studies of interaction between humans and their work environment took a long time ago, back in ancient Greece and 19th century, and the field of ergonomics itself has becoming an independent discipline that started to emerge only after World War II. Now, the Human Factors and Ergonomic Society was founded in 1957, and their mission was to promote the discovery of knowledge concerning the characteristics of humans and that are applicable to the design of systems and devices of all kinds. Now, ergonomics in itself have a lot of interventions. They can improve the workplace efficiency, they reduce costs, they can decrease waste of materials and equipment, and increase employee satisfaction. Now, what are work-related musculoskeletal disorders? Um, they're defined by the CDC as musculoskeletal disorders in which the work environment and performance of work contribute significantly to the condition, and the condition is made worse or persists longer due to work conditions. These work-related disorders have an enormous impact on productivity, and they represent an important opportunity for ergonomic intervention. According to the Bureau of Labor Statistics, WMSDs, in the private sector, in 2018 resulted in 27 cases per 10,000 workers in the United States on average, requiring 12 days for return to work. So you can see the economic impact of these injuries, accounting for lost wages, compensation costs, and loss in productivity. I think it's estimated by the National Academy of Medicine to be around somewhere between 45 to $54 billion a year. So that's a pretty hefty sum. And I do think it's important that we take that into consideration. So, essentially, the prevention of these disorders relies on avoidance of seven specific high risk activities. Repetition, which is defined as cycles that are less than 30 seconds, or one basic activity element present for more than 50% of total cycle time. Prolonged or repetitive exertion of more than 30% of the operator's strength. Body segments that are held in an extreme position. Prolonged static posture. Activities with vibrating tools. exposure to cold, and a combination, of course, of both conditions. Now, as you can see, several of these high-risk activities are common during surgery, including the repetitive movements that require, think, significant force on your body and your upper extremities, and you just are always in this awkward position. But really, if you try to stand with correct alignment, prolonged standing is not necessarily very injurious. But in general, for workers in any industry to reduce the risk of occupational low back pain, experts recommend keeping extremities close to the body as much as possible. Try to use a compliant mat underneath the feet to decrease spinal disc impact, and alternating between sitting and standing. I think trunk rotation is also a significant factor in low back pain. And usually, I think the laparoscopic surgeons suffer from this, especially when they are doing that twisted motions, and sometimes also because of their incorrect monitor positions. These disorders are associated with performance surgeries are common across multiple surgical specialties, and today we'll be focusing more on the urological aspects of those surgeries. Prevalence. So, a systematic review and meta-analysis evaluating 21 articles reporting prevalence of WMSDs among surgeons and medical interventionists. With the majority, I think, of these articles were from general surgery, urology, and gynecology. But what they really showed is there was a pooled prevalence around 17% for degenerative cervical spine disease, 18% for rotator cuff pathology, and 19% for degenerative lumbar disease, and 9% for carpal tunnel syndrome. The impact on surgeon practice is pretty impressive. I think 12% of physicians with these disorders take a leave of absence, or they modify their practice, or sometimes even opt for early retirement. Survey-based studies showed a range of 55 to 95% of surgeons reported some kind of discomfort related to surgery. Pain is typically in the hands, arms, neck, and back and shoulders. And in another study of 561 spine surgeons, I think 7% had undergone surgery themselves for lumbar disc disease, 4.6% for cervical disc disease, and 32% took time off from work for these musculoskeletal disorders. So you can see, even us as surgeons, we got to take care of our health, because down the road, this could lead to a lot of surgeries. And so the American College of Surgeon members conducted the survey, and the survey showed that 40% had had sustained a WMSD, although 50% had received medical care for it. Only 19% reported them to their institution. So you can see here that some surgeons are underreporting their injuries, and it may be due to a belief that pain and discomfort are a cost maybe of the job in a field centered around patient care, not surgeon comfort. A lot of surgeons do commonly report that they do continue to work through their pain, so that the quality of their work will not suffer. So there are several studies out there that reported higher rates of WMSDs related to endourological procedures. There was this one study that I came across, 120 urologists, where I think 70% of them reported some kind of musculoskeletal disorder that was related to the urological procedure. Interestingly, it was related to transurethral resection of the prostates, or TURPs. The most common areas of pain were in the neck, back, and shoulder and hand. And 5% reported having the need to stop surgery or postpone subsequent surgeries due to the pain. There was another international survey that found that 85% of urologists had experienced some kind of musculoskeletal complaint in the past year. 50% experienced chronic complaint, and most commonly in the neck, back, and shoulder. Endourology and traditional laparoscopic surgery were risk factors for chronic symptoms. And I think about 5% of surgeons required a leave of absence of more than 1 week, and about 15% required leave of absence of uh, more than a week. Although most surgeons, about 90%, felt ergonomics were important, only a third of them rated that their knowledge of ergonomics was as good or excellent. The same systematic review showed that the prevalence of these musculoskeletal complaints were associated with robotic-assisted laparoscopic surgery, and 56% complaint of chronic WMSDs in these surgeons. The most common sites of discomfort for robotic surgeons were the neck, hand, wrist region, including the thumb and fingers. So, as I was saying, and not that they only affect your muscles and joints, they also affect your sleep. 40%, 50% of these surgeons reported sleep disturbances, and it does in fact affect your personal relationships. And we can see, just based on this small amount of data that I looked into, that there is this significant impact on a surgeon's quality of life. So again, these WMSDs, although the data is limited, but we do know that major implications regarding caseloads, practice patterns, and career longevity are affected. I think there was another research article that I looked into that showed that 15 to 35% reported that WMSDs affected their surgical performance, and 70% of them actually reported decreasing their surgical caseload as a result. And in another study, 22% of the surgeons reported missing work days due to these WMSDs, with an average of 7 days per surgeon per injury, and 35% reported performing fewer procedures after their injury. And in a further study, 9% of surgeons performing minimally invasive procedures reported stopping their surgical practice altogether due to these injuries. Of note, about 25 to 30% of surgeons actually do consider musculoskeletal disorders when planning their operative route, and unfortunately, sometimes this does lead to switching to more invasive techniques. So the cost of this on the surgeon itself, um, I read that the truncated careers that can occur because of musculoskeletal injury may be problematic, since it takes many years of education to become skilled for a highly specialized surgical procedure. Training surgeons is expensive, and this must be factored into the cost of sacrificing surgeons' health and career longevity due to suboptimal ergonomics. So in general, some of the risk factors that we can see in the operating room itself include inadequate lighting, lights that require adjustment with one hand or frequently during surgery, tripping hazards over wires, operating table variables. Sometimes it's too wide, sometimes it's too high. There's some difficulty maneuvering with obese patients and improper arm positioning. Foot switches requiring surgeons to stand on one foot to reach to reach the pedal. Some common risk factors seen in open surgery is, of course, prolonged static positioning, use of retractors, and The use of surgical loops, headlamps lead to increased neck flexion. In endourology, because they are prolonged procedures, we do a lot of repetitive movements and adjusting the visual terminal workstations and the monitors all do cause a lot of neck pain and back pain. Some risk factors seen in robotic assisted laparoscopic surgery is the prolonged sitting, the tendency of rolling chairs to move farther away from the console throughout the surgery. Actually, the surgeon himself has poor awareness of correct console settings, leading to excessive back and neck flexion, and constraints of viewing angle, about 40 to 60 degrees on the console, and adjustment range. Something else to note is we as surgeons do help a lot in lifting the patients and transporting them. It is important to know that we should utilize lifting and transfer equipment. Also, we should have a no lift policy, and I think ergonomic training and education actually does help in this procedure because you can try to avoid acute muscle injury or pulling on things. So you can see here in this picture here to the left, table height should always be at 75% of distance from the floor to your elbows. You can see here how this high table here in the red is problematic. But if you bring it down to 75%, you know that you have your elbows resting, you don't have to arch your hands over. Your feet should always face the surgical field at a 90-degree angle, perpendicular to the table. And when you're operating, whether open or laparoscopic or endourology, you should always try to tuck your chin to minimize the forward head movement. That really helps with the neck pain and shoulder pain. When standing, you should always try to keep your pelvis leveled, as on the picture on the left. You don't want to be standing on one foot or putting weight on one foot. And whenever you lean forward, try to hinge at your hips to help with that back posture and the back pain. So it's all about posture, posture, posture. When we're in the operating room, especially when you're doing stones or endourology or you're using the cystoscope, make sure that you place the display monitor directly in front of the user with the upper edge of the display at eye level and the center of the screen slightly below eye level. As you said, the operating table height adjusted should be to the height of the operating room table to maintain the hands close to the elbow, with elbows at the 90 degrees and upper arms and shoulders relaxed. When surgeons of different heights are present, the table height may be adjusted for the tallest surgeons, and all other surgeons may utilize a lift or a stepping stool for the best ergonomic setting. We should adjust the table height and the surgeon's standing position to maintain the hands near elbow height. As you can see here to the left, the work in the box theory. You always want to keep your hands in that box. And here again, this is a picture of a stepping stool. Always adjust the table for the tallest person in the room, and then everybody would have to stand on the stepping stool accordingly. So some unique ergonomic problems in endourology. Endourological procedures are usually associated with prolonged static positioning and repetitive movements, as we all know, and these usually create a high risk ergonomic situation. There was this one study that had identified two major risk factors for WMSDs after endourological procedures. It was actually surgery and medical conditions such as arthritis, and as I said, I think earlier, prostate resection and prostate size. Operations with larger prostate size were associated with both the occurrence and the severity of WMSDs. The number of surgeries, standing versus sitting, and corrective eyewear usage, type of working element, and type of monitor did not affect the risk of WMSDs. And this picture here to the left, it just shows you how important screen positioning is. You don't want to be looking down. You don't want to be looking up. You actually want the monitor right in front of you, perpendicular at a 90-degree angle to you, to help with that, because you don't want to be flexing your neck all the time. And same thing goes for the pedal. You don't want to be, trying to lean forward, or this happens a lot to me when I'm working on stones. The pedal's not right in front of me. It's positioned in an awkward way, and I have to start reaching out for it with my leg and having having to put a lot of weight on the other joint. So these little fine things over time do really affect, and you do feel them when you go home. Also, when maneuvering or using the cystoscope, as we all do, use it a lot. You just want to make sure that you maintain a neutral wrist position. As you can see, this picture on the left, you want to maintain that neutral wrist position. You can see on the left that awkward. You see how he's flexing his wrist to hold on to the cystoscope. All that will cause joint pain, arthritis, etc. So you want to make sure that your one hand is parallel to the cystoscope and the other is perpendicular. That way you don't have to be flexing. And when we're doing our TIRP procedures, or any other procedures where we're sitting down on a stool, try to have your chest lean forward and pelvis backwards, and just try to position your weight just anterior to the ischial tuberosity. That way, you decrease the load and stress on your back. So some problems that we see in robotic surgery. It's usually just the way we sit on the console, especially for the residents who are starting to learn how to use the robot, and for the younger surgeons, just making sure what settings are appropriate for you, in terms of being in that position where you are comfortable enough and you're not leaning forward and you're not flexing your back and your neck. But really, these little tricks do help over the long run. They do recommend that neck flexion should be less than 25 degrees, as you can see on the picture to the left. Your shoulders and upper arms should be relaxed. Elbow angle should be 90 to 120 degrees with the console. There should be a less than 15 degrees, sorry, back flexion. And your thighs should be parallel to the floor and your knees bend 90 degrees. You want a good chair with sufficient lumbar support. You can adjust the height, and also lock the wheels, because you don't want that. You don't want to start drifting away during the operation. And for your foot pedal, you don't want to be dorsiflexing more than 25 degrees. Actually, you just want that less than 25 degrees, just like when you're driving a car. And when you're looking into the console, just make sure you tuck your chin in, to minimize that forward head when using the robot. So prolonged sitting without appropriate lumbar support will create more intradisc strain than standing. The robotic console viewing angle is restricted to 40 to 60 degrees, requiring a flex posture that causes strain in the neck and trunk. And this is something that I did not know, but surgeons that are shorter than 175 centimeters in height cannot place the armrests at a suitable height for their ergonomic positioning. Likewise, the optic height can only be adjusted to an acceptable range for surgeons who are 155 centimeters to 200 centimeters, to be seated in a neutral position. So really, I think when they start making their newer robots, they should take into consideration people who are not in that height range. But some of the challenges that we faced when using the robot is, like I said, the prolonged sitting causing the lower back and neck fatigue, The rolling chairs that drift away increases the reach and strain. Bad posture if not adjusting your console design, and head and neck is not really in its optimal position if you're with the limited view angle. So as we said, for your chair, you want a non-sliding, non-rolling chair to avoid creeping away from the console. You do want to adjust the console to fit you and not the other way around. Um, the six-step adjustment order is chair height, chair close to console, forearm support, head support height, and head support angle, and as well as pedals. So why do surgeon ergonomics matter? Because we work long hours and we're usually in these awkward postures. All that leads to muscle fatigue and injury. And poor ergonomics means reduced precisions, more errors, and more mistakes, and we're not able to take care of our patients in the way we want to. So I'm gonna take a look at some of the recommendations and guidelines out there. So again, like I said, it's all about posture, posture, posture. When you're in the operating room, visualization is really important. You want proper lighting and display orientation because those can have adverse effects on the task you're performing. You want the headlights right above you. You don't want it coming from behind or above. Sorry, from an angle. You want it directly parallel to your head. That way you can get that maximum light. And really, stress is a big factor for us surgeons. Surgery related stress is caused by time pressures, equipment problems, poor or layouts, crowding, newer technologies or ortho technology that you're not really used to, and unexpectedly you just have challenging patients. So all of these affect the physical and cognitive workload, and these stressors accumulate over time, and they do manifest in many forms, including excessive fatigue, reduced performance, mood swings, and reduced quality of life. Some general recommendations. They do say that you should move regularly during your surgery. There is this big clinical trial at the University of Michigan right now, talking about microbreaks. So they do recommend that taking about up to a 2 minute micro break every 40 minutes does really help surgeons in terms of musculoskeletal injury and just being able to complete the case without a lot of physical and mental stress. Um, you should always make sure that you're always aware of your posture throughout the case. I myself try, when I'm working a stone mid case, I realize, like I'm leaning a lot and I try to keep my back upright as much as possible. And as all the residency, Dr. Costa will always tell you, keep your back up. And I really think ergonomics is one of the reasons behind it. um, be aware of your shoulders and upper arms when you're operating. Just give those brief pauses every so and so just to recheck everything, make sure that you're in the right position, you're comfortable. I usually do that frequently, where I would like, for a second, focus on my body orientation. You want to keep your upper arms close to your body as much as possible, perpendicular to the floor. Drop your shoulders and relax your hands. Limit shoulder abduction to less than 30 degrees and have a slight inward arm rotation. And I think for open surgery, whenever you're using the retractors or you're suing or something like that, always just Make sure that retraction duties are rotated among the assistants. Because really, retraction can kill your hands and back. Optimizing OR equipment and setup. So you should they do recommend using anti-fatigue mats, sorry, to reduce foot and leg strain. You want to cover cords with lace covers or mats to prevent tripping. Yesterday, me and Dr. Marino were doing the stone case, and there was wires everywhere. You have the X-ray machine, you have the laser, the cords of the cystoscope. So just make sure that is taken into account because you don't want to trip and fall. Make sure before you start your case that the overhead lights are adjusted because you don't want disruptions during the middle of your case. The monitor setup, as we talked about, you want the screen at below the eye level or just at the eye level. You don't, and really your field of view should be 15 to 45 degrees below. And the recommended screen height is 160 centimeters, and I think it's 80 to 120 centimeters away from you. So you don't want it to decrease eye strain. So you don't want that to be too far away. We try to, as much as possible, avoid instruments or tools with high pressure contact areas and sharp edges. Use trigger locks, ratchets, or other features to minimize the sustained gripping and squeezing of forceps. In robotic surgery, try to use a clutch to move the master controls to the center of the workspace, and use the armrest to offload arm weight while keeping the shoulders down. Hold instruments using a power grip to minimize finger fatigue whenever possible. To the right here, you can see that open finger grip versus the open power grip, because you don't want to be, putting a lot of pressure to open up an instrument. It should not require more than 15 newtons per the guidelines. A force to fully close. I don't know what 15 newtons feels like, but I can just imagine you don't want to be applying too much pressure, to open up or close a clamp or a hemostat or etc. Again, elbows, forearms, and wrists. You want your elbows flexed between 90 to 120 degrees, and keep your forearms horizontal at a neutral position between supination and pronation. Um, for your wrists, you want a slight extension and bend fingers. You want to avoid extreme wrist angles more than 30% of the time. And like we said, when we're using the cystoscope, just try to maintain a neutral wrist position as much as possible. Your neck, you want it flexed between 10 to 30 degrees, avoiding twisting as much as possible. When using the robot, you should have light contact with the robotic headrest. You don't want to be, leaning against it or all of your weight up against your neck. And try to avoid that head forward slouch by straightening out your back. Try to stand close to the patient as much as possible when you're either operating open or endourological or just assisting at the bedside on robotics. And you want to avoid reaching your feet, hip and width should be apart, knees unlocked. And every now and then, like I said, just do some postural resets where you stretch your foot, do a quick squat here and there. Just, that mini exercises to stretch out your muscles. You want to avoid prolonged, uneven standing where you're putting more weight on one leg over the other. You also want to avoid excessive knee bending, especially when you're using the robot. Your feet should be flat on the ground, 90-degree angle at the knees. Again, like I said, the foot dorsiflexion should be less than 25 degrees when using pedals. So it's just like when you're driving a car, you don't want to be overreaching or trying to um, move around with your foot. Your foot should be dead center on the pedal. And you can also consider support for long surgeries. The foot pedal is a component to consider the hose support for. And pushing the pedal with the foot rotated laterally may cause hip discomfort and injury. That's why we should when you press on the pedal, you want it to be straight ahead and not not jumping around. Again, when you're standing, you want to be adjustable. Standing support to be adjustable between 80 to 100 centimeters to reduce prolonged static postures. You can also use arm boards. You want your arms tucked when possible to avoid twisting the torso. And again, when you're standing close to the bed, especially when you're doing a stone case, you want the pedal at your foot aligned with instruments and target, and you don't want to be standing on one foot again. So this concept of um, micro breaks has been going around a lot recently, and I think again the clinical trial done at U Michigan does show a lot of utility and potential. But primarily the concept is you want to take 1 minute breaks every hour, and to cut on muscle fatigue, boost focus and motor control, improve performance. Some other research studies do report a little bit more longer breaks. There was one study that actually supported 5 minute breaks, which showed less stress and no time loss. Another study looked into 20-second micropauses, and that actually showed 7 times chance of having fewer errors. And another study where it looked into 2 minute guided exercising during your OR actually caused less shoulder pain. Some intraoperative exercises for your neck. You can use the left, the deep cervical flexor training. So you move your neck in each direction 10 times every 20 to 40 minutes, or when experiencing stiffness in the neck. And these, are just extension, flexion. You rotate it to the left, you rotate it to the right. Just try to get your muscles moving because you want to try to avoid that muscle soreness and stiffness. Um, when you're standing, you can also do that scapular retraction. It really helps, especially when you're lifting heavy equipment or you're holding the ureteroscope, especially the rigid ones, the long ones. They're inside the patient's body. You don't want to. You're making these tiny movements slowly. You don't want to injure the ureter, so you're holding that ureteroscope, which is it's not heavy, but it does have a considerable weight, and you want to hold it in position. That really puts a lot of stress on your back. So if you're working with a second surgeon and you take turns, just make sure you do these small exercises. Um, so range of movement exercises. Like I said, the deep cervical flexor training is you nod your head up and down as if you're indicating yes. And you uh, uh, yes. I'm sorry. So so exercises to stable your neck and shoulder. Like I said, the deep cervical flexor training. Also, you want to hold your closed fist between your chin and chest and flex your neck for about 10 seconds. You should feel the front neck muscles engage. They recommend repeating it 10 times throughout the day. And do this exercise without an actual fist, if scrubbed. The standing scapular retraction is where you pull your shoulder blades down and towards the spine, pulling your upper trapezius down away from the ceiling. You hold for 5 to 10 seconds, and they recommend that you repeat it 10 times. The cervical and shoulder stretching. This is for your upper traps. You gently bring your ear to your shoulder with your hand while placing your opposite hand behind your back, and you hold this position for 30 seconds. They do recommend that you repeat it 2 times on each side. Um, this levator scapula stretching, you gently look at your armpit while placing your hand on your head for a slight overpressure, and then you place your opposite hand behind your back, holding this position for about 30 seconds, and again, repeat 2 times on each side. The pectoralis exercises is where you place your forearm against the corner of a wall and step forward with the ipsilateral foot. While looking ahead, just gently bend the forward knee and the contralateral leg remains straight. You do not want to hyperextend your lumbar spine, but you should feel that you're stretching out your pectoralis or anterior chest wall. Again, hold this position for 30 seconds and repeat 2 times on each side. Some of these exercises would be difficult to do when you're scrubbed in, like putting your hand on the wall. But in between cases is really good time where you can get these mini exercises to help stretch out your muscles. Another one is techniques that improve thoracic mobility. You'd use a foam roller for thoracic or lumbar mobility. You place the foam roller perpendicular to your spine and slowly roll up and down on the foam roller using your feet to move while you are arching back to extend the spine. And make sure you just always support your neck. And you can perform this for 1 to 2 minutes. Um, Another exercise you could use with the foam roller is where you place it under your spine and you engage your core to maintain full spinal contact with the roller. Allow your arms to extend toward the floor, stretching your anterior chest wall. And this position can be held for about 30 to 60 seconds. Again, repeat 2 to 3 times. And of course, they also recommend some exercises for your fingers. Because as surgeons, we do use our wrists, hands, and fingers. Lumbrical stretching, where you stretch your lumbricals in different directions with all the digits extended and the wrists in a neutral for 5 seconds, and then you can repeat that 5 to 10 times. Passive wrist extension with your elbows straight also will help prevent that, the median nerve entrapment and the risk of carpal tunnel. And yeah, there's a variety of these exercises that they talk about and on the guidelines. And actually, I can once the rounds is done, I can share these. There's an actual PDF that was that I looked into from the American College of Surgeons. It's a bunch of exercises for surgeons in general, and I think it's good to have some kind of idea of them. So some key takeaways from my talk today. Ergonomics isn't optional; it should be essential. For all surgeons, down the line. I can imagine all these musculoskeletal injuries over the years and the years when you're towards your 60s and 70s, they catch up to you. So for all the younger surgeons or residents in training, just make sure you're aware of that. Try to avoid that micro tear and wear as you progress through your surgical career. Following the guidelines out there for ergonomics, although not very clear and obvious like other kind of guidelines, but some exercises that we talked about to get in do help. Micro breaks are proven by research to actually work. So you just see what works for you the best, whether you want 2 minute breaks every 20 minutes or every 40 minutes, or you want the micro pauses every 40 seconds. You just really have to tailor to what you like and train smart and operate smarter. Thank you.
Any questions, comments, Ramon?
Hey, Mo, I think, Dr. Bernard, um, I think this is very pertinent to endourology. We have many of these issues, and I've seen the field evolve, especially from the time when we did not have screens, when you had an ocular, you had to put your head down to meet the ocular wherever the patient was. So I think it's important to know the things that are available. That in the operating room, for example, in the cystoscopy room in downtown, the table has controls that has quite a few options in terms of height and tilt and Trendelenburg and reverse Trendelenburg. Um, and then there are some pedals that are touched more frequently, like when you're touching the laser pedal. It's important to be aware of where it is, not to have it far away. And these are things that I find that the staff don't always arrange for you, but it's important to want to arrange it. If you are tall, like Tommy Metzner, then I think it's important that the height accommodate the tallest person, just like you mentioned. And then the rest of us can work with the pedal, with step ups. It's a little bit difficult to use a step up when you have a pedal that you have to accommodate as well. You have to put the pedal on a step up so it'll be at both the same height. So the options are important to know. And it's also important to know what kind of equipment is hard ergonomics. I think of one of them is the Pathfinder squishy. It's a little bulb with two one-way valves that you irrigate when you're doing endoscopy. And for a small hand, like a female's hand that is smaller and with thinner structures, that can be laborious. So it's important to know what the other staff are going through in terms of how they use equipment that is more taxing on them. And good ones that I've seen that I'm eager to see is there's a new ureteroscope by Wolf. It's not so new anymore, but I've been eager to use it. But it keeps your hand in a totally different approach to the handle and the movements and the deflection. It keeps the wrist in neutral. And the fingers are used in a much more ergonomic way as the DURS. We haven't started using it here. It's unfortunately more expensive than the other ones, in my opinion. So anyway, these are things that I think in the operating room is important to be aware of for urologic endoscopy. Thanks.
Mo, thanks for the talk. I believe very much in trying to consciously be aware of posture every time you're in the OR, whether you're robotically operating or doing open cases. And that is what you guys as residents are so focused on the case and what you're doing. That one thing we do just to concentrate often is look more closely at something. And you don't even realize it, but you're bent over the table because you're so in the moment of trying to complete a task. And that's usually when I say stand up straight, is because your eyes work and they work the same whether you're close or far. And especially if you're wearing loops, you can see just fine. And I just want you to try to maintain your posture awareness. And the second comment is mini breaks is a very useful thing. And I took a gazillion of them yesterday. We did 2 long urethroplasties. And if the guy's bleeding a little bit, it's you just put a Raytech in, hold pressure, and you just kind of close your eyes and relax your shoulders and just take a breath and just zone out for a minute and then come right back to the case. I find that in my old age, a really quick refresh and reset. And I encourage you guys to incorporate that in your practice too. It was a really good talk, Mo. Thanks.
Mo, I'm going to give you a couple of comments also. Yeah, this is really, you may think this is not science, but this is actually very pertinent. And and everything that Dr. Costa said. See, robotics has helped my back over the last 20 years by sitting there, but still your neck is still, so you have to get really, when you're at that console, get really comfortable so you're relaxed with that. And the other thing is with, we're aging a little bit here in the staff. I mean, stretching is really important. I mean, now where I am at, I'm stretching every day, this, that, and the other thing, because, and that helps you. So might as well get in that, and also being active, not sitting on the couch, just being active helps with all this. Because if you look at other people, they have all sorts of bone problems, back problems, and things like that because of inactivity. So that's also a good thing to put into your lifestyle. Thanks.
Thank you, Dr. Bendick. Yes, agreed. Thank you, everybody. Yes, excellent comments.
And the other thing, more this talk didn't touch on are the lead aprons. Because, in the endoscopic surgery, we have to choose an apron that's not terribly heavy because that can put a lot of strain on our back and neck. So when we choose our aprons, just be mindful to choose the lightest apron possible. And that's another occupational hazard for urological surgeons or anybody doing work with radiology. The other thing is just this is an anecdotal now. I bumped into Shane Hester yesterday at North, and Shane had worked on the new robot, the X. And one big difference is you can bring the console to you rather than us having to bend our neck against the console. So, and he told me that he has done 3 cases and he can already start feeling a difference in his neck because of the ergonomics of the new robot. So I think, there are a few developments, but I think that might be one advantage with the version 5. Okay, just
That's great to know. Very eager to work on the new robot. Yeah, it's interesting. I failed to mention the lead aprons. Actually, I was looking at this interesting study where they said that the two-piece apron is a lot better than the single piece because the weight distribution is a lot better. Um, Personally, I don't know if I'm going to like wearing 2 pieces, but that's just something out there for the audience to know.
Okay. Any other questions or comments? If none else, I really want to applaud the residents for really making this grand rounds more holistic, looking at different topics, just not focused on urology itself, but looking at the big picture, what Marco talked about a couple of weeks ago, and you doing this. I really appreciate the perspective you guys bring, and thank you for doing this.
Of course, thank you, Dr. Balaji. Thank you, everybody.
Thanks, everybody. Have a great week.